President and I, the Secretary, the administration believes that the example you gave relating to essentially preventative care here, which is really what you're talking about, can be universally applied to all chronic diseases. That, if I'm not mistaken, and correct me if I'm wrong, because I always joke, as Roland knows, I say they call me an expert in foreign policy. That's because it's easier than healthcare to deal with. But if I'm not mistaken, close to 70% of the total cost to the system is for chronic disease. 75%. And so, is it accurate to say that if we were able to focus more on prevention, that we would not merely have what we all care about, because you all got this business because you care about caring for other people. But there's a second dimension to this, and I don't want to sound cold-blooded about it, and that is that there are two constituencies that exist generically out there. One is the constituency that feels passionate about taking care of the very underserved communities you talk about, Doctor. And there's another that don't not care about that, but their greatest focus is, from a conservative point of view of smaller government, saving money. And it seems to me we've reached a point here where there is a confluence of interest between people who view themselves as socially conservative and economically conservative in terms of being more of the budget hawks of the world, and those who have entered this profession as well as politics for the purpose of the social change that they want to see accomplished. I mean, we're at a moment, and I'll close with this comment. I think I've been involved in public life for a long time. I got elected when I was 29 years old in the Senate. I've been around a while. I've never seen a more propitious moment in the United States of America where we are, and I think we are closer with all the shouting and all the political turmoil surrounding this issue. I don't think we've ever been closer to being able to do something substantial about providing for a better, a cheaper, a more efficient, and a more effective healthcare system than we are today. So I want you to understand, Dr. Mink, I think you are maybe a little concerned that my focusing on the cost side means I don't care much about the social side. I got started in the civil rights movement. I was a public defender. I was around when Dr. King was still there. That's why I got involved in politics. But I do think we're missing an important point here if we don't demonstrate to the American people that the federal government getting involved in trying to come up with a more rational system can have the economic impact of not only ending up with a more rational system delivering better health care, but saving taxpayers tens of billions of dollars over time. So my rhetorical question can be answered if you wish, is the example relating to asthma, is that equally as applicable to heart disease? Is it equally applicable to other diseases out there? And if it is, just give me a few seconds talking about it.
So if I could talk about heart disease, because heart disease is the #1 killer of both men and women. And our lifetime risk is increasing in the United States of having heart disease. For a man, it's 1 in 2 of developing heart disease. For women, it's 1 in 3, and it's approaching 1 in 2. More women are dying of heart disease than men in absolute numbers. Our goal is, to prevent heart disease. If we can work as a society to prevent heart disease, we'll not be paying for the care for chronic illness as heart disease. If we can start targeting our population, screening them as young as the age of 20 for high blood pressure, for cholesterol problems, helping them quit smoking, helping them with weight loss, we are all going to save money. One example, I get very frustrated in my clinic is that I have a lot of overweight and obese people, and of course 2/3 of the United States is either overweight or obese. These are the people who need help. They're going to develop diabetes or heart disease or high blood pressure as a consequence of their weight, in addition to other medical issues. So this is the group of people that I'd love to refer to a dietitian. They don't need me, they need someone to help them how to eat right, how to exercise, how to lose weight. Well, unfortunately, the only way you'll get referred to a dietitian where it's covered under any insurance plan is if you're diabetic. That's too late. I mean, it's great. I want to send my diabetics also to the dietitian, but I want to send the people before they have diabetes. And it's very frustrating because these are the people that we can actually change the impact of their health. And I think ultimately heart disease prevention, as well as any other prevention, is like the asthma example. If we attack it early, if we start screening people early, even if we cover the basic screening for the cardiac disease risk factors and screen these people often and treat them aggressively, we're going to lower the risk of them developing heart disease.
I'd like to make a comment on that, if I might. In our state, I think we're a forward-thinking state. No offense to anyone from other states, but our Attorney General...
President agrees with you.
Our Attorney General, Lisa Madigan, has really put together initiatives to actually improve access, and with improved access, hopefully improvement in terms of preventive measures, because people will now come into a hospital, hopefully get connected with a primary care doctor, and hopefully start getting more preventive care. But as Dr. Whitman talked about what he's doing in this, in his initiative here at Mount Sinai, I started thinking again about cost. You know, if you look at business models, sometimes you have to throw a lot more money at something and be visionary, looking down the long road and seeing what's going to happen. Will the outcomes be better? And I think it's really important that before we close, we talk about comparing treatments. I'd really like to touch on that very quickly, because it impacts my patient population quite a lot. The President has talked about comparative effectiveness research, and it's been tagged as rationing, and it's absolutely ridiculous. We need to look to see primarily if some of the care that we're throwing at people, the treatment options, are really effective. Right now, the Food and Drug Administration, when they look at drugs or device for patients, they're looking at whether they're effective and safe. But we have to take that one step further. We have to look down the road and see if these treatments really, in the long term, provide the kind of outcomes that we're looking for. And not to start looking at these kinds of treatment sites either through head-to-head clinical trials or other kinds of measures would be ridiculous. We cannot compare our system to the one in England. We're not England, we're the United States. We cannot say that because there might be holes in their system that will happen here. We need, as we go forward, to start looking really closely at different treatment options, seeing what works. Sometimes, for instance, for back pain, I have patients who come in, they're older, with what we call spinal stenosis, narrowing of the spinal column, and they have lots of pain because there's pressure on some of the nerves coming off. They get these so-called sciatica types of pain that patients come to you and complain about all the time. Having an operation, we will tell you, at least in our literature, the geriatric literature, doesn't work really well. Having physical therapy works better, more effective, and in the long run, it's much more cheap. I don't believe that the plan is to look at cost ahead of outcomes. But when you look at outcomes, if outcomes show that they're better, in the long run, cost will be improved. So I think we cannot have a program going forward without looking at cost effectiveness research.
You were asking about how much we could save for caring for chronic diseases, and I think heart failure is a good example, and asthma is a good example, but if you think about something like diabetes, really the opportunity for savings is in preventing diabetes. And Steve Whitman's example about how moving out into the community, whether it's through community health workers, through our educational system, we need to improve the health of our population, and that's going to be the greatest way to decrease our medical costs. So we can't keep the focus just on the healthcare system.
I think as citizens of this country, we're all a participant in this debate. We own a piece of coming up with an answer. I think we have to ask ourselves, what is it about the current situation where we're not taking advantage of the kind of preventive health measures that Dr. Whitman, as an example, has demonstrated, and plenty of other examples out there, of the benefits of preventive health? What's wrong with the structure of the health insurance system and the healthcare delivery system where we're not taking advantage of that? As we go forward in the healthcare reform debate, that's something we really have to ask ourselves. What are we doing wrong, and what can we do to do better?
For me, prevention is the answer.